Okay, just to review, the test will go live at 3:15 and be open till 2. It's actually 2:15 tomorrow instead of 2:30. It's the standard 75 minutes. So I think as long as you start it by 2:15, 1 o'clock tomorrow, you should be able to get it done without getting timed out. If there's any problems, email me or message me. But just what I kind of want, let me start off, and hopefully some people respond. Or are there any questions or something you didn't understand from the notes, the PowerPoint? Let me let me say something. I did record, or does somebody want to say something? Ask a question? I did, on the second video I recorded, I played a video of them waking up a horse in a pool, and I zoomed in on, or I tried to pause, there was something called an oxygen demand valve. So the horse had a tube coming out of its nose, which was probably, it was nasopharyngeal intubated. And the reason they would do that, so sometimes they'll intubate a horse from the beginning of a procedure, if it's like head and neck procedure, something to the mouth. So if they go through the nose, they can bypass, the oral cavity. But if they're waking up and a horse starts chewing, they can keep the tube in longer. Now, usually if you have a trouble oxygenating, like say that horse had problems during anesthesia, say that horse had problems with its oxygen level, that may be a reason to use a nasopharyngeal tube, because then you could keep them intubated longer. Maybe their nasal cavity was plugged up. Remember, if they have a lot of nasal discharge, once you pull a tube, a horse has to be able to breathe through its nose. So those would be indications like, why would we put a nasopharyngeal tube in? Give oxygen after the procedure, have an open airway, nasal cavity was obstructed. And then in the video with the pool, they had that little button and it was hooked up to a green hose, and that's called an oxygen demand valve. It's kind of like a flush valve directly hooked up to a tube. Now that horse is in a pool with all of the weight of that water on the horse, which is going to make it very difficult for that horse to breathe. So she would periodically push that button and it would kind of give the horse a breath. It would give a blast of pure oxygen. Now, I'm only guessing in that horse, it was probably due to the weight. If you think about that horse, he's still sleepy, and that horse is in the water. How are they going to be able to expand their chest in that raft? So in that case, it's probably to help the horse breathe after a procedure. Now, one thing in the notes that I don't want you to get confused, there was, how do we induce horses? It talked about nasotracheal or nasopharyngeal induction in a foal. So in a foal, you can place a nasal tube, like you can numb the nasal cavity, and this would be like in a very critical foal, but you could put the tube in nasally and have them inhale the inhalant, kind of like how we do a mask induction, except you're gassing them down via this nasoendotracheal tube. Because remember, a horse isn't going to, or nasopharyngeal, sorry, a horse isn't going to let you put a tube in their trachea if they're awake. So a nasopharyngeal, the tube only goes to the back of the pharynx and they inhale the gas, and then once they're asleep, you can advance the tube into the trachea. And remember, intubation in a horse is what's called blind, meaning you're not going to, if I didn't stress this in lecture, you're not going to open a horse's mouth and be able to pull their tongue and be able to look back there with a laryngoscope. All you do in a horse, it's nice and simple, is you pull out their tongue and you slide the tube, and as long as you don't hit resistance, it should slide into the trachea. And then usually I have someone, you would like push on their chest and you would feel for air, because you're not going to feel for placement, okay, because it's way too thick of a neck. We don't have to worry about pushing the tube too far because their necks are so long. The tube would never go past the thoracic inlet. So the nice thing is you just put it in and you either secure it to the top of their jaw. We usually use a padded halter or remove their halter. Does anyone know why I would remove a halter on a horse that is anesthetized? Like, why would I not want to have them laying on their halter? Imagine all the pressure. And exactly. And what happens if they have facial pressure? If like a horse lays for an hour and a half on a buckle on their face, what do I worry? Nerve damage. So what you worry about is neuropathy. Neuropathy happens in a horse when they are laying on a nerve, and when they wake up, pressure has been on the nerve, and so you might wake up and the horse might not be able to blink in their eye. Their lip might be droopy on that side. Their ear could be drooping on that side. So if you see any, again, their face should be symmetrical. If my eye was drooping and my lip was drooping, well, people, they might say you had a stroke, but that's some type of nerve damage. And in a horse, that's called neuropathy. Now, tying up, Haley, I'm glad you asked that question. Tying up or myopathy is different. What happens is when you have a horse laying down, okay, on their side, or they could be even on their back, blood is going to pool. And what happens is we have to get good blood pressure and we have to get good perfusion. When the horse doesn't have, if they have any hypoxia or if they have any impairment of blood flow to the muscles don't get oxygen and then they tie up. So myopathy can come from pressure, but it's a different problem. It's not a nerve problem, but it's a problem that the muscle did not get good blood flow and did not get oxygenated blood flow. And then the muscles will feel hard. Like they don't, like if you push on muscle, it's kind of squishy. It's not very medical. But what happens is that muscle gets tightened. And even sometimes you can look at a horse and it looks like it's knotted. And that is due to a lack of blood flow to an area of muscle, which means if they don't get blood flow, they don't get perfusion. And if they don't get perfusion, it's called tying up. So I just want you to make sure you truly understand the big things we worry about post-op is neuropathies and myopathies. The way we try to prevent that is to have good padding. Remember, if they're on their side, their legs need to be parallel, down like forward, scissor, like a scissor position. Good padding. Don't over tie them. Don't overextend the limbs. Make sure for neuropathies, make sure they're not laying on any hard surfaces. So usually a horse, if they do have a halter, we had a halter that we put bandage material, like the padding. So if the horse had a halter, it was at least a padded halter. So they weren't like on a buckle or like a hard part of the halter. Don't overextend, pad well. Let's see, pad well. Make sure they're not tied extensively. Make sure we have good blood pressure, good blood flow. So some other complications, colic. Now, colic is abdominal pain, and it can be, now like when a horse colics, at home, it can be a grain impaction. It can be like a fecalith, which is a fecal stone. So when I'm talking about colic, is there anything that we do anesthetically that will predispose the horse to colic? Well, anesthesia slows everything down. Are there any drugs that I worry about? I mentioned one drug specifically that we use in caution in the horse because it can affect their GI motility. So there was a drug I specifically said that we should not use. So morphine, you have to be cautious because opioids do slow down the GI tract. I don't tend to use morphine in horses because they're sensitive and they can have like morphine mania. But there was another one, even more specific. Acepromazine we use is okay. Acepromazine slows things down. It begins with an A, and we use it protectively. We use it in a pre-med, and it's not an anesthetic. It's considered an adjunct. Atropine. Atropine Miranda. Atropine. So atropine, which we usually pre-treat because if we want to like decrease saliva, if we want to prevent bradycardia, but the problem is it slows down the GI tract. So atropine is not routinely used in the pre-med. Now, again, I've told you, if you have a bradycardic emergency during surgery, you have to give atropine. That's all bets are off. If we're using it in an emergency, like if the heart rate was to drop due to vagal stimulation or the horse was crashing and we have to give atropine, you give it. But if we're not going to give it as a routine pre-med because we worry about gut motility. Okay. Now, make sure you review procedures, standing. So remember, the 3 levels of anesthesia in a horse is light sedation, which might be like hoof or teeth floating. You have standing chemical restraint, which could be like a laceration repair, a minor surgery, something that's a little more intense. And then you're going to have full general anesthesia. Okay, so Katie, that's a good transition. If I need to anesthetize a horse, you need them, because standing sedation, they're very deeply sedated, but they are not anesthetized. Standing sedation, they still have their reflexes. I'm going to answer that in just a second. But remember, standing chemical restraint, there was a picture of the horse, wide stance, droopy lip, droopy head, ears down. Okay, we almost never see a horse standing like that unless it feels like absolute crap. But a horse should be very up, aware, on guard. They're flight animals. But if you need deeper, if we need anesthesia, there's TIVA, which is total intravenous anesthesia, and then there's general anesthesia. TIVA could be like in the field, and that's all injectable anesthesia. So they are fully asleep. Like when Dr. Pohl, I showed the video of him doing the castration on that horse, that is TIVA. Now, it said total intravenous anesthesia. He gave a pre-med, and then he gave an IV agent, and the horse was asleep. We didn't have a tube. We didn't have oxygen. We didn't have inhalant. If you're in the hospital for like a colic, an orthopedics, something that's more in depth, then you're going to do general anesthesia, which is an intravenous protocol. Remember I know in the video I talked about triple drip. So triple drip is usually like the ketamine, the xylazine, the guaifenesin. You bolus those drugs, guaifenesin you can titrate, the other drugs you bolus. You intubate the horse, and then you're going to put them on inhalant, typically isoflurane via a ventilator. So that's in hospital. Now, in the lecture, you could have a horse come to your hospital and do TIVA, and maybe that's where the confusion is. But the TIVA is also called field anesthesia, because when you go out in the field, if you go to somebody's barn, you're not dragging an anesthesia machine and inhalant and tubes. You are literally going to just use injectable drugs, and you're not going to have all of that other stuff. You're not going to have you might have like an SpO2 monitor, but you're not going to have like a big ECG and an oxygen, does that make sense? Does that answer your question? Does anybody not understand the difference when I say TIVA versus in the hospital anesthesia? So you have to think about it this way. what kind of procedures can I do with what things? So again, if we just have to shave down the teeth, in the PowerPoint, it talks about examples of procedures to do under light sedation, like in radiology, if you had to take some x-rays. Most horses don't just sit there and put their hoof on a block. They need some sedation. Teeth floating is light sedation. Maybe to clean a wound, like they got a scrape. But if you have like a deep laceration, an ovariectomy, an eyelid surgery, that would be standing chemical restraint. Those are procedures where you do not need the horse laying down. You can do those with the horse standing, but you need them deeper than lightly sedated. Does that make more sense? And then you have something like abdominal surgery, like if you're going to do a colic, or we're going to do like an orthopedic surgery, anything involving a joint, anything going into the stifle or a carpus, that's an invasive, deeply invasive, painful procedure, then the horse is going to have to be on general anesthesia. Now, again, the nature of a colic and an orthopedic surgery, they need to be in a hospital, in an OR, in a sterile environment. If you're going to do like a castration, that would be, you could do TIVA, which is generally is like a form of an anesthesia, but you just don't have like the oxygen and stuff. But you're not going to open a horse's abdomen in a field. I mean, that needs to really be done in a hospital because of all of the complications that go with a colic. You need oxygen, you need monitoring, you need ventilation, you need inhalant. Does that answer your question better, Katie? There were slides in your PowerPoint where it listed like light sedation procedures, standing chemical restraint, and then when you get into general anesthesia, you can do TIVA, which is all intravenous or intramuscular techniques, or you're going to do in hospital, which is typically your IV intubate. Ovariectomy can be done in a field. Generally, that type of procedure, they need a special scope. So they usually will probably want to they would prefer to have that done in the hospital because of the special equipment. But a horse does, that's what I'm saying. Like some procedures, like horses came to Purdue, we didn't always put a tube and use gas. An ovariectomy, the reason it came to Purdue is because of all the scope. There was a lot of special equipment that they didn't want to drag out to a field. Okay. But in generalities, I just want you to know, if you're in a field, if you're in somebody's barn, you're not dragging out an anesthesia machine. You may have an oxygen tank for emergencies. I mean, I think that would be prudent. Maybe have, like emergency drugs. So you're going to take supplies with you in a truck. You're going to have some of your hospital has to be mobile, but you're not going to take some of that bigger equipment out there. What other questions do you have from that PowerPoint? And I don't know if I stressed in the video, I'm like trying to remember back what I said in the video. Post-operatively, things that I'm very concerned about. Exactly. Who just wrote that? Okay, so there was a question posted. It said, one of the questions asked about why nystagmus is detrimental in recovery. The reason nystagmus can be detrimental is that if a horse tries to stand, and this is what the person wrote, if the horse tries to stand while their eyes are going like this, the body is going to follow the eyes. So if a horse tries to stand, they're going to just do a big old somersault. And the concern is that they are going to fall over and potentially break their leg. That's the big danger. Roll, hurt someone. So if we see nystagmus and you have a horse that's trying to stand, they need to be sedated. Now, what kind of drugs do I have if I have a horse waking up like this, how do I sedate this horse so that they don't stand? Because sometimes, like I said, your goal is to wake them up, but right, xylazine or acepromazine, you need a sedative. A lot of times in these horses, it's not necessarily a pain thing, it's an excitement thing. And again, some breeds are going to be worse. Like, I'm not a fan of really working with thoroughbreds or Arabians. Both of those are breeds that are very flighty, very high energy, kind of wound for sound, so to speak. Give me a gold, a Belgian, a quarter horse, a warm blood. There's some breeds, I mean, it's just like dogs. I mean, when I wake up a husky, I am anticipating them screaming bloody murder, whether they're painful or not. And sometimes I have a big old basset hound that's just like, whatever, So you get to know breeds are kind of, you know, have their personalities. It's no different than horses. So you want to, you're probably going to have some acepromazine or some xylazine on board, that if you see kicking, nystagmus, sometimes they're throwing, they're thrashing their head. Those are all signs they're trying to stand. Those are all signs that they're trying to wake up. But the nystagmus is the big thing, that if I see that horse is not ready. And if you saw that horse in the very first video, it was almost like a typewriter. It was following his eyes, his head. Well, if he tries to stand, boom, that's what's going to happen. Not always, but that's why we have a big padded stall. If these horses are flipping all over the place, all equine recovery stalls, the walls, the floor, everything is padded so that hopefully if they roll or fall, they don't hurt themselves. But if they get their legs stuck in a weird position, that's a lot of weight going on a limb. Gotta be careful, okay? Okay. Any other equine? So intubation is blind, and when I say that, it means you do not watch when you put in the tube. You open the mouth, slide it in. And remember the other, colic, rolling, biting, thrashing, kicking. Some people tell me like bad heart rate. Okay, what I'm talking about is if I walk by a stall and I'm looking at a horse. Now, I'm not touching it. I'm not listening to it. I'm not running a blood test. I'm literally just looking at a stall and I'm looking at a horse. What do I see a horse doing that would concern me that there's a possible colic? Okay, rolling, kicking at the abdomen, biting at the abdomen. If you try to feed it, not eating, because normally horses, that last recovery video, the guy says horses are simple creatures. They just want to stand and eat. A horse typically eats about 3 hours after anesthesia. So if it's been 3 hours, you feed the horse and they're still not eating, that's kind of a red flag, because most horses want to eat pretty quickly. That's why we have to put the basket muzzle on them, because if they don't have food when they wake up, sometimes they try to go through the sawdust and the bedding. Well, we don't want them to eat the crappy hay that they lay on, and we don't want them to eat any sawdust. So a lot of times we put a basket muzzle so they can drink water right away. And then in, about 3 hours, we give them their food, and then they can eat. But if they're not eating, rolling, kicking, biting, all bad signs. And then atelectasis, because they're so heavy, the weight on their lungs, they're going to be depressed. They're not going to breathe very deep. So they're already going to have collapsed alveoli, which is atelectasis, and it's areas of collapsed lung, non-functional gas exchange. That's why we breathe for them. Now, if you're doing field anesthesia, there's no, you're not going to have anything hooked up. But if you have a horse in the hospital, You're going to have them intubated, probably on a ventilator, and you're going to breathe for them. And if CO2 goes high and hypoventilation gets worse, you turn them down and you breathe for them more. That's how you reverse it. If it's collapsed alveoli, how do you reverse it? How do you fix it? It's no different than when you guys are going to be in small animal anesthesia, is helping your patient breathe. Oh, the acronym for ventilation, let me type it here, is, hang on, Caitlin, I'll answer your question. If I could type, that would be helpful. Oh my God. CPPV is continuous positive pressure ventilation. When you put them on a ventilator, you take over breathing for them. You are breathing for them. It's continuous. When you guys do it in small animal, and I said give them a breath every 3 to 5 minutes, that's IPPV, which is intermittent positive pressure ventilation. It means you're just doing it intermittently. One here, one there, whenever. So you're not doing it, ventilator is continuous, intermittent is you bagging. The problem is in a horse, those bags are huge. You're talking about a 15 to a 30-liter bag. And if you try to squeeze it, like I said, maybe you're Shira, or, you know, you guys are strong. Caleb and Peyton, I'm not ruling out the men here, but when you try to squeeze it with your arms, it's extremely difficult. So it's just going to be more efficient. We don't even like let them get depressed. You just put them on a ventilator. Now let me go back and read Caitlin's question. They were doing equine surgery. So on Yukon Vet, she said they were running and jumping on the ribs with their shins to initiate breaths. So it's a very scary thing. I got to do, they had a horse, when I was a student, they had a horse arrest during anesthesia. And they had to do CPR. And this big farm guy, well, there's two farm guys that were the anesthesia techs, but this one was a really big guy. His name was Bob. He was an awesome guy. He was running and leaping onto the chest with his knees. Because imagine if you do this to a horse, you're not doing anything. So people were taking turns running and just jumping onto the horse's chest to try and get the heart started. Now, something that you can do when your patient isn't breathing, and when the patient arrested in surgery the other day, I take my fingers and I dig into their ribs. It's kind of like you're almost tickling them. I mean, sometimes people are like, I'm like, get in there. That ain't doing nothing doing this little. I like reach in and I'm like, you're almost like rubbing the ribs. And sometimes I'm like up under the diaphragm in their ribs. And sometimes that'll get a dog to get breathing. Sometimes it's one of my little tricks up my sleeve. And people are amazed. They're like, man, that seems to work every time you do that. I'm like, not my first rodeo. But second, you're kind of stimulating between the ribs, and sometimes it'll initiate, it'll kick them out of apnea. In that case, Caitlin, yeah, they were probably trying to get some rib stimulation or to move some air. I don't know if on the video the horse was arrested or if the horse was actually just coming out of anesthesia. But the more that they try to push on the chest, they're going to move more air. They're going to start to kind of wake up. It's just the stimulation. It's kind of like when you guys start to wake up patients from anesthesia, sometimes people are just like sitting there watching them. I'm like, rub their head, talk to them. I mean, I've seen people flip them, which you have to be careful about. But like I squeeze their paws. I kind of like do bicycles with their leg. I mean, we're just trying to stimulate them. The more we can stimulate them, we can hopefully get their heart rate going, get the drugs out of their system, and they're going to wake up. That's the goal, what we're trying to do. Okay, well, the other thing to think about is the other two things that are on this test. I want to make sure there was no other confusions with equine. the positioning, why it's key, side effects, talk about sedation, but the pain medications, the lecture on pain, remember to be familiar if there's a certain block, is there any type of procedure that would match the block? Like, you know, and remember there was a question on the homework, and I think I answered this, that talked about there's preservative-free morphine, which is the opioid of choice for epidurals, and there was preservative-free lidocaine or bupivacaine. When we don't use preservatives, we're worried about a reaction. A preservative just makes the drug last longer. So when you open it, like propofol does not have a preservative. You have to use it in like 6 hours. So if I use morphine with preservative, I can keep that on my shelf. When we have preservative-free morphine and we crack it, we have to use it within 6 hours. If I have bupivacaine without a preservative, you have to use it within 6 hours. So that's why we don't use that stuff for everyday procedures. But in the epidural space, we're really cautious that we don't want to get a reaction to the preservative. That's why there is preservative-free forms of morphine. It doesn't help its duration. It doesn't make it more effective. All we're worried about is a reaction, okay? I think I answered some of the pain medication stuff from the homeworks. So like, why do we do certain blocks? What is the benefit of the analgesia? And remember, if I'm talking about the whole goal of analgesia is multimodal analgesia, which is using different agents to achieve analgesia via different receptors. Because there's opioid receptors, there's alpha-2 receptors, there's, our COX receptors, and they all have a role in pain. So if I give an animal 3 different medications, I'm treating pain at different receptors. I'm going to achieve analgesia. Now again, sometimes you have a dog neuter, and sometimes they have a femur fracture. They're not probably going home on the same analgesia protocol, but if I send home more than one drug, we're just hopefully going to achieve better analgesia. And we talked about that's the reason for preemptive analgesia, is that if you stop the pain before they feel anything, it's going to be much more advantageous. If you've ever had a headache and you could not get Advil until you got home in like an hour, and then by the time you get home, you're like, oh my God, my head, it's much worse than when the headache started. I mean, headaches can get worse. If an animal feels post-op pain and we don't treat it, and then it gets to that, remember there's primary hyperalgesia, which is where they're sensitive near the area of injury. And then there's the secondary hyperalgesia, which is the windup. If we don't treat it, then the nerves are fire, 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 fire. And then all of a sudden, we get into this secondary hyperalgesia or windup. The dog hurts kind of everywhere, or you go to touch them and they're hyperreactive. It's because the nervous system has been bombarded with signals, and it kind of goes into this windup. So it's been proven, if you stop the pain before it starts, you can use much lower doses. If you're treating an animal that's at windup or secondary hyperalgesia, you're almost going to have to use double your doses. To achieve analgesia, then you can decrease dosing. But like I said, I always wish I could say, wow, at 4 o'clock, I'm going to get a headache, so I'm going to take Advil at 3:30. And then I probably won't get a headache, but that doesn't happen. If I know I'm spaying a dog at 10 a.m., let's give morphine at 9:30. So maybe by the time we spay, because remember, your general anesthetic, propofol, induction agent, no analgesia. Isoflurane, no analgesia. So we have to give them something preoperatively, so hopefully when we do the surgery, they aren't as reactive. Okay. Now, as far as the canine and feline anesthesia lecture, that seems like ages ago, we talked about intubation. So we talked about, pros and cons. What is unique about feline intubation? Oh, okay. There, just got a question that says, what are the flow rates for oxygen? Let me answer that while Katie's typing some stuff. When we have an animal intubated on a system with a bag, usually we're running 1 liter of oxygen. When you put them on a mask for induction, you're going to usually use 3 liters of oxygen. And when you put them in the chamber, which is the aquarium, that's 5 liters of oxygen. Okay, so you're going to gradually go up. Yes. So for a cat, we usually are recommending having lidocaine and a stylet. What's the lidocaine for? Am I doing a local block? Is that why I need lidocaine? Am I squirting it in their eyeball? Yes. So I'm trying to be funny. Yes, laryngospasm. So not the paralysis. You guys are laryngeal. You're on the right track, Melissa. So they are prone to laryngospasm. You're fine. You're on the right track. I know what you meant. Yes, Michaela, cats are very sensitive to lidocaine. So no more than 0.05 or 0.1. So not 0.5, 0.05 to 0.1. But the lidocaine we squirt, so hope, because cats, if you even get near their larynx with a tube, they can laryngospasm and they can actually turn blue and stop breathing. And you cannot force a tube in there. You never, because then you're going to cause laryngeal edema, and then you got a worse problem. So the best bet is to squirt some lidocaine, be patient. I love how people squirt it and try to intubate. And I'm like, then why did you even put it on if you're going to try to intubate them right after you put it? It doesn't work that fast. It's fast. It's not that fast. And you don't inject the larynx. You're dripping it. It's a topical administration of lidocaine. And then as the cat breathes in and out, it's a timing. Okay? So as they open, you put the tube in. Now, some cats will cough, and some cats, I've had some, they're very spastic back there. So, but as long as you get the tube in and you tie it in, then you're good to go. And then the stylet, cat tubes are kind of flimsy, and sometimes it's hard. A lot of people have opinions. You're in my class. The only opinion that counts right now is mine. Because I've had people argue this with me, not you guys. Because people say, no, you don't, or this person didn't use it. I don't care if they don't use a stylet. You want a cookie or a medal? A stylet is going to give a tube rigidity, and it's going to help intubate the cat. I don't want to be dinking around with a flimsy tube not able to intubate them. So I personally, when you go out to practice and maybe someone trains you and maybe you work with someone and you get better without stylets. Now people worry about stylets because they worry that if the end of the tube, if the stylet comes out the end, and you could puncture the trachea, but you have to use them carefully. I always make sure there's a stopper on the end of this, so the metal does not go past the end of my endotracheal tube. So I will not use a stylet if it does not have a stopper, and that way the wire just stays inside the tube. So as long as you have a good stylet, you shouldn't puncture the trachea. And speaking of the trachea, that's why we disconnect when we flip, okay? Sometimes people are like, so tubing doesn't get knotted, so tubing doesn't fall out, so tubing doesn't do this. It's not a tubing issue. If you twist the patient and then the cuff is too tight, you could tear the mucosa and we worry about tracheal tearing. Okay, so the best thing is to disconnect, flip your patient, reconnect them so that tube doesn't get, and again, it's a little more critical in the smaller patients, but you can still cause micro tears and tracheal irritation in a big dog. And I didn't mention this when I did recovery, but normally I warn owners when I discharge patients that it is common to have a little bit of a cough when they go home. So I usually tell owners a day or two of coughing is going to be normal. I mean, it happens in people that are intubated, they go home and cough, but the coughing should get better each day, not worse. And the coughing should not interfere with eating or sleeping or drinking water. If a dog is coughing to the point where they can't finish a meal, if they're coughing to the point where they can't drink water or they can't get a good night's sleep, there may be worse irritation than we thought. We may have to do cough suppressants. So I just told owners, I said, just look for these things. And if your dog, a little hack here and there is going to happen. But again, it shouldn't interfere with those basic sleeping, eating, drinking type activities. And it should only get better, not worse. But that can be an indication that maybe there was a tear. Maybe someone flipped them, and we got to worry about that. As far as dogs and cats, we only have like 1 more minute, and I know your test is going to go live. So do you have any other questions for me? As soon as it'll take to convert these videos, it's not instantaneous. What I'll do, I start the conversion of the video, I copy the link and I send it. It's just depending on YouTube how long it takes to go live. So I can't guarantee when I first send you the link, it's going to be active. And we also have a staff meeting at 3:30, but I will have my phone out. So I'll be on a live Zoom staff meeting. But if you need something, again, text or email if you're having problems. Okay, if there's nothing else, then I will probably let you go, and good luck. And then I'll send out, tomorrow closer to class time, I'll send out, we're moving on to cows and pigs. Triple drip, ketamine, xylazine, guaifenesin, or the alpha 2 of your choice. But typically it's ketamine, xylazine, guaifenesin is your triple drip. JXK. No, G. I know my alphabet, it's Monday. GXK. Guaifenesin, xylazine, ketamine. Thanks for asking that. You guys are asking me some good questions. That's good. All right. Oh, you want me to type that, Katie? I don't know what your question marks mean. That's the abbreviation. A lot of people call it GXK for guaifenesin, xylazine, ketamine. So sometimes people are like, let's do a GXK drip. Sometimes people call, because triple drip, yes, Katie, Pollock, that's the horse triple drip.
So I got a question.
Yep.
The MLK thing, that's morphine, lidocaine, and ketamine, but what's it used for again?
It's used for post-op pain, or I'm sorry, well, usually it's dripped in intraoperatively at very low, like microdoses. So it enables you to keep your inhalant very, very low, and you drip it in for pain. So the ketamine in that is not keeping them asleep. You're going to get a little bit of sedation with that. That's mainly an analgesic drip. So it's used like usually with the inhalant during surgery. Sometimes it's used, and then it's usually maintained post-op.
So is the MLK like the GXK for small animals?
Well, okay. Sorry, I had to ask him. So MLK is, there are 3 drugs, so but it's never called like a triple drip. MLK is a post-operative analgesic, like intraoperative, post-operative analgesic, CRI. And the GXK is an induction drip. So it's used for induction of anesthesia. So they're used differently. And I won't add Kitty. Now, Kitty Magic is 3 drugs, but that's given in the muscle. Now, Kitty Magic would have more of a relationship to the triple drip, because except in Kitty Magic it goes IM, 3 drugs goes IM, and in the horse the 3 drugs go IV. Both are inducing anesthesia. You're just giving them differently. Now, I'm going to tell you, I didn't stress this in horses, but you don't usually do a full IM induction protocol in a horse, because the way it's absorbed is random. So it can take a while to induce them, and you can get some excitement phase. So in a horse, the best way to induce a horse is going to be intravenous, and you drop them quick. You don't even let them get into an excitement phase. That's why it's a bolus technique. That's why we don't mask horses down, because we get into excitement, and we don't want to do that. Okay. So the MLK I talked about with the pain lecture is a pain CRI, can be used in surgery and after surgery, but the GXK triple drip in a horse is used to make them go to sleep. Now, usually triple drip is turned off and you're put on gas, but if you were in a field, you could do triple drip out in the field to keep them asleep and not put them on gas. Does that make sense? Hopefully that makes sense. Okay. Sorry. And that's why to be honest, I don't have people memorize a ton of protocols, because you will get, your people mess with them all the time. If you know the job in that protocol of each of the drugs, you understand what the protocol does. Okay. But something like triple drip is foundation. Kitty Magic is a foundation. MLK is a foundation. So understanding what are in those protocols, I think, are good to know. Okay. Any other questions? Okay. You have a good day. You guys, good luck. I'm going to end this so I can try to get this converted before my meeting. And I will see you guys tomorrow. Bye.